Welcome, everyone, to Our Whole Lives Taking Flight webinar series. My name is Amy Johnson. I am the Minister for Sexuality Education and Justice in the United Church of Christ. And I'm here today with some folks who are going to help facilitate a conversation around the framework for dialogue and stigma and HIV and AIDS. So I am delighted to have them introduce themselves. First of all, I will pass it over to my owl sister, Melanie Davis from the UUA.
Hi, I'm Dr. Melanie Davis. I am the Unitarian Universalist Association's Our Whole Lives Program Manager. And I'll throw it to you, Arthur.
Good afternoon. My name's Arthur Butler. Reverend Arthur Butler. I am the National Coordinator for the Framework for Dialogue, and I work with United Church of Christ. And pass it on.
Hello, everyone. I am the Reverend Michael Crumpler, and I am the LGBTQ and Multicultural Programs Director at the UUA, and I live in New York City.
Great. So again, welcome everyone to this webinar. A couple of logistical things before we get started. First of all, if you have any questions, please put those in the Q&A at the bottom of your screen. You'll see there's a Q&A and a chat feature. So we ask that you put any questions you have during this webinar in the Q&A. Feel free to introduce yourselves or say hey to anybody in the chat. Melanie and I will be moderating those features throughout our webinar today. I am going to start us off with a little reading from a book called Fragments of Your Ancient Name by Joyce Rupp. And this reading is called The One Who Calls. You communicate with my secret self and invite me to stretch beyond my fences, to listen to what aches deep inside, to face disruption and find growth there, to accept the reality of imperfection, to live deeper in the heart of the day, to not lean on what others might think, to accept affirmation without excusing, to enter conflict with loving respect, to grow deeper in union with your love. So with that, I'm going to hand it over to Arthur to give us some information about what the framework of dialogue is, and also to talk to us about the stigma index and how that intersects with his work with HIV and AIDS, and also we'll have some connections with how that intersects with our work as Our Whole Lives facilitators.
Well, thank you. Once again, I am here to talk about the framework for dialogue. The framework for dialogue is a tool that brings together a group of individuals. And within that group, we have our religious faith leaders, faith-based organizations, networks of people living with HIV, and I'd like to add to that our service providers, people who provide services for people living with HIV. It is a conversation that brings those individuals and organizations together to have conversations about stigma and the impacts of stigma, and how that either prevents our barriers to going to our places of worship where we might be stigmatized further. So these conversations are formed to create joint actions, but we go through a series of moments and times together where we question what stigma is, what are the impacts of stigma, and it's important to have our faith and religious leaders at the table. That's a key component to the framework for dialogue. And so the question begs to answer, why then are religious leaders important to the process? Well, religious leaders bring an extensive experience with dealing with social justice and other issues within the community, their knowledge of the community, their reach into the community, their passion for the community, their influence within those communities, the trust and the confidence that people put into their faith, religious organizations, and in certain cities, even the control of capital that is distributed within those communities. Now, the goal of the framework is to strengthen a response from faith communities and religious leaders with people living with HIV to effectively address key concerns, experiences, and needs of people living with HIV. And the National Alliance of Mental Illness identifies 7 different types of stigma. I'm going to just go through a few of them, but if you go on to their website, they have extensive descriptions around each of these different types of stigma. The first type is public stigma. And public stigma happens when the public endorses negative stereotypes and prejudices, resulting in discrimination against people with health conditions, mental health conditions, health disparities, those type of things. Then there's self-stigma. And self-stigma is what happens when a person uses their disorder to internalize that public stigma. There's perceived stigma, and that is the benefit of having negative interactions with people with these disabilities. So the consequences of dealing with the stigmas is that when people are stigmatized, what happens is that poor treatment is received when receiving services. Another consequence is that it creates problems in acquiring or keeping employment. Another consequence is negative profiling or stereotyping, which fosters discriminations, increases fear, insecurities, and it perpetuates a silence. And there was a slogan back in the early HIV outreach and messaging that said silence equals death. And we know that when we are silent, in the 12-step programs, they say that silence equals death, but that we are as sick as our secrets. So it causes us to go inward. And if we don't have the support as we're going inward, it creates additional consequences. One is that it creates an unsafe environment, and it can lead to violence, and often, sometimes death. It violates human dignity, and it erodes respect for human rights, and it can result in psychological and spiritual harm. The framework is person-centered, and that's a word that we hear sometimes, but it's person-centered. It's a dialogue that begins with the experiences of people living with HIV, and how living with HIV impacts their ability to practice their faith, and how that impacts the impact of the work of the faith institution on their lives. So how we worship, what prevents us from being free to worship? What are the barriers that keep us from wanting to go and operate in systems that promotes truth? One of the principles of the framework for dialogue is a do no harm. And it's do no harm, which means that all of the participants in the dialogue agree to do no harm, that we sit down and we say, we're here together, we have shared experiences, we're not trying to make one person's voice louder, but that we're equal in this together, because we all are being harmed when we don't hear one another. To have an equal and meaningful participation in the process. That means that everybody has a stake, that enters into the room, that enters to the, that sit at the table, and that they allow room for full participation and involvement in any decisions that come up throughout the process. And basically, innovation is a key principle. Innovation means that we form new partnerships, that we rely on out-of-the-box thinking and solutions. These things are encouraged. The framework for dialogue has been conducted in Detroit, New Orleans, and Baton Rouge. And what we found that each of the states that we went into, each of the cities that we went into, after the stigma index, and the stigma index is what moves the process. That's the evidence, because this is all based around evidence. So a stigma index will go in and talk with the community and prioritize the needs of that community, looks at the gaps in services. And when they have those things, then the framework comes behind the stigma index, and we marry the two. We have the conversations around the stigma index and the data that has been produced. And with the database partnered with lived experiences, it moves us to a place of having joint actions. And from those joint actions, hopefully the conversation can create a sustainable conversation, but we first must have the conversation. So I'm not sure if you want me to stop there, Amy. I'll be glad if you have some questions, I can answer those questions.
Yeah, we do have a couple, and Melanie, I saw you had something, so why don't you start us off?
Yeah, I'm wondering, you mentioned that you have traveled from city to city to do this, and I'm wondering, is there is it a citywide, like, do you come up with plans that people in cities can institute or to reduce stigma, or is this something that then the individual faith communities, like, does it trickle down into individual faith communities?
Yeah, that's a good question, Melanie. Thank you. It's really about that partnership and putting together of the people who come to the table. And that's why I started out by talking about the importance of why it was important to have faith and religious leaders at the table, because of their influence, because of their reach, and because of the trust and the confidence that is placed within those organizations, so that as they start to build, and it's a joint process, so as they're starting to build from those conversations, the joint actions are really the final steps, because really it's about having the dialogue. Now, I'm from a large family, and we always had our best conversations around the dinner table. And so if we can bring together in that do no harm atmosphere, in a safe environment where we can start talking about those key issues, then we're open to looking at what we have that's more alike than what we have that's different. And from those things, we then start to build upon those joint actions. And maybe that might be participating in World AIDS Day, or it might be participating and having materials out in your place of worship, or that the action might be that one of the religious leaders might talk about stigma and the impact, or might allow someone living with HIV to address the congregation. But it's really, that's the innovation. So it's about doing things that you may not have thought that you could do before.
Thank you. We're getting a couple questions about the stigma index. One person's asking if we have a link to the website that you were mentioning, Arthur. So, so if you've got that at some point and can drop that in the chat, that'd be great. And the other question is there an example of how the awareness of the stigma index impacted or shaped next steps, which I think you just talked about a little bit, but am I understanding, I just want to kind of to frame that a little bit more. Am I understanding that when you bring all these folks together, you bring the religious leaders together and you bring the service providers together and folks who are living with HIV together as well, and people are telling their stories and people are learning about stigma, that's breaking down some of the barriers and the stigma that people are carrying around HIV?
Yeah, so it opens up the possibilities to have conversations. And in that safe space that we're talking about, it's also, and I see that our Reverend Mike has put the stigma index link up, so thank you. But what it creates in that safe space is that faith and religious leaders can also come to the table knowing that it's not an attack on what the church isn't doing or what the church needs to do, but really looking at the key issues around the impacts of stigma and how those barriers are created.
Great. Thank you so much, Arthur. And I'm also wondering, you know, and I know Michael's going to talk about this a little bit too, but just wondering about what some of the myths are that you see in your work that are persistent. You know, sometimes I think, especially those of us that are in progressive religious communities like the United Church of Christ and the Unitarian Universalist Association, can think like, oh, we're totally cool with HIV. We've got this, we understand, we teach about it, all this stuff. But what are some myths that you see that persist, that and some of those stigma pieces that are kind of persistent, that still need work being, you know, bringing down those barriers?
Yeah, so remember I talked about public stigma and how that impacts what we do or what we don't do. One of the things that we notice, and this has been a challenge of bringing faith leaders to the table. And really what we've heard from our faith leaders when they come to the table is that some of these topics they were concerned that they weren't able to talk about or didn't know how to talk about it or how to bring it up, or were concerned about what the congregation might say. And some of those myths are that, you know, they're the old myths about how HIV is transmitted and whether it's just because of moral issues. And so those things come out, but that's why it's important that we're building and working from the foundation of the data that has been collected. And so the data leads that conversation. And so that they get to talk about the data versus perceptions, though perceptions are important, but those myths around how HIV is transmitted and that it's a moral issue and that if you weren't doing this, you certainly wouldn't be in the place that you were in. So breaking down those things. And then also even on the public side, about what the role of the faith organization is. And so you get to see those and have those conversations. And that's what makes it so rich, is that you provided this a safe space. You've agreed to do no harm. You agreed to have equal participation within the process. And you look at the strength of building partnerships.
Great, thanks. I think this would be a good time to give you a little rest and switch over to Michael. And one of the things that, a couple of things we asked Michael to address are the kind of the intersections of this topic with racism and healthcare access, and some again, some misunderstandings of the prevalence of HIV and folks who are at most risk, and who still tends to be stigmatized, and how that impacts accessing treatment. So over to you.
Thank you, Amy. Arthur, amazing, amazing, amazing work that you're doing. I think that it is so key, and thank you so much for highlighting it, because I think that in order to overcome stigma, it's more than just, telling people not to stigmatize. I actually do believe that it takes work, and there has to be a strategy, and there has to be a variety of folks at the table, like the UCC, the UUA, and other welcoming, open and affirming, inclusive faith circles have done a lot of good work, hard work around ensuring that, we're allies, we're supportive, we're welcoming, we are changing our theology and moving theology towards a space where, folks who are, queer, trans, LGBTQ, people of color can feel centered and safe, and still there's stigma. I've been all throughout faith, Protestant faith. Born in the South, missionary Baptist, in the 90s, coming of age in popular evangelicalism. I have a bachelor's degree from Moody Bible Institute. I came out and then, went to a UCC church, and now I'm working for the UUA, and I've been all over. And I can say that Protestant churches are just as, progressive congregations and churches are just as uncomfortable talking about sex and HIV and sexuality as conservative ones. It is still not safe for folks to come out. I've been living with HIV for 16 years, and the stigma didn't begin with HIV. It never begins with becoming HIV positive. It is the social determinants that make it likely for people to become positive, that where the stigma begins. I had that self-stigma that you opened up with, just by virtue of the fact that I was gay, and coming from a very religious family, I just didn't see space for me in that. And that stigma led to, behaviors and activities that put me at risk. Now, not everybody who's HIV positive were engaging in risky behaviors. That's my testimony. But that is not everyone's story. But for me, those social determinants of religious persecution, living in the South where we just don't talk about those things, going to church where we just don't talk about those things, and being Black where, in order to survive, you have to be the best Black person you can be, and being HIV positive didn't seem to fit that. So all of stigma begins in all those spaces. And I think that, as you mentioned, like bringing different folks to the table, having these discussions is key. Today, there's still stigma attached to, but I think that most of us, I live in New York City, as I mentioned earlier, and I live in a community of folks who are HIV positive. I don't have friends I don't know too many people. It's really the HIV negative people who are closeted here in New York City. It's just not, it's just like an assumption when, it's like, what, you're not, like you, you're not positive, like not you. So it's something that we have worked really, really hard here. I know when I received my positive test results, I was living in Columbia, South Carolina, and I was like, I am getting out of here. I will not be able to survive here. And for me, it was like fight or flight. And I fled to Chicago, where I lived there for several years before moving back to the South of North Carolina, where in North Carolina, like if they know that you're positive, at least this was the case when I moved to North Carolina, the health department comes and like visits you. And, it's like, it's almost like a probation officer, like knocking on your door to make sure that you know that it is still illegal in North Carolina to transmit. I mean, it was a very, like, I remember like I was living with my sister and I mean, like my whole family knew I was positive and like, we were in the living room and I was just like, and at this point I had been positive for several years, but I just happened to be living back in North Carolina. And that was stigma, and it wasn't that my sister didn't know. It wasn't that my, at the time, 10-year-old nephew, well, he didn't know, I mean, but like, it was still like this weird, uncomfortable thing. And I was just kind of like, I would hate for other people who have to experience this, but it was literally a public health visit. And so I left there and moved back to New York, where it's like housing's available, SNAP is available, like healthcare is available. It's just all just so natural and so smooth. And I just feel like culturally, depending on where you live in the States, determines your stigma. Now, I mean, there's still some stigma, like on the dating apps, folks are it can be shaming if you're positive. I've always personally led with that, not because I felt like everyone needs to know, but I just needed to go ahead and like, it's like, it's like clearing myself of people that aren't safe. Like, it's just not, I just don't have time. I don't have time to, explain or apologize, or I just don't have time. And I think that it's that, for me, it's that kind of attitude. And I see it in New York City. You just don't have time. If you're not with it, fine. It's like when I go into a space and I'm new, or new people come into a space that hold power, I just want things to be on the up and up. Not because I owe it to anyone to be that free, but because I want to stay free. And I just don't have time for trauma. I don't have time for drama. I don't have time for rejection. I don't have time. And so, I just try to like do that. But again, I know that that's not everyone's privilege. A few years ago, a UU minister invited me to St. Croix, and I've been twice to discuss what it means to live with HIV, how to move beyond stigma. And my audience was primarily healthcare workers. Now, depending on where you live, I mean, St. Croix is the United States, like medication treatment is available, but in those communities, number one, it's dangerous to be out, it's dangerous to be trans, and it's dangerous to be HIV positive, particularly amongst Black heterosexual women who oftentimes, are left with the burden of what it means to be living with HIV. They may have children, they care for parents, they basically are the most employed. And so small things like going to the clinic that sees itself as offering services and being sex positive and helping folks out, just going to that clinic becomes kind of outs you as being HIV positive. And then people at that clinic who may not have sexuality awareness and don't necessarily know how to be discreet and how to maintain privacy and HIPAA, how you call someone into an office, which doctor they go to, and which hallway they walk down inside. But then maybe the housekeeper or a delivery person sees you in that space when they drop off, whatever it is that can out you and put you at risk in your communities. And so again, St. Croix is the United States, but it's not very different in the South. So these are the things that folks need education about, and not only that, like we deliver medications to folks, as to prevent them from having to go pick them up for the pharmacy and so forth and so on. But then people get mail all kinds of places. You may not have a post office box. Someone may open up. So there's all kinds of, things. I heard stories from women who have to like receive their medication and put it in a different bottle, and they have to, and so all that to say that today, yes, we have made a lot of advances in HIV, but how those advances trickle down to the lived experiences of people who are already stigmatized and marginalized, is important. Another thing that has become popular is the U equals U, untransmittable equals undetectable. What that means is if you're immune, if you're viral suppressed, which means that you're taking your therapy or your medications regularly, then you are what we call undetectable, which means that like there's not enough HIV in your system to allow you to transmit HIV to your partner. And so that science revealed that in recent years, and that's great. And so it's so important for folks to know that people who are living with HIV are not necessarily a threat. But what does that mean? That means that you have to be taking your medications every day. It means that you have to, which means that you have to like be in an environment where it's safe to take your medications every day, which means that you have to have stable mental health that in essence minimizes the trauma of what it means to have to be reminded every day that there's something different about you or something unique about you. That means also that you have to be, socially or situationally located in areas where medication's available and those conversations are available, and all of these things impact treatment. So yes, U equals U. However, that message falls on deaf ears if it's not communicated in spaces of risk.
Wow, thank you, Michael. Thank you so much. Thank you for your transparency and your vulnerability and your knowledge, your deep knowledge of so many intersections with this. I wanted to just stay on the outing people thing for a second, like all the ways that many of us may not think about how people are outed, and the ramifications, like you were saying, the ramifications of that in spaces where it's not safe. I was thinking about when you were talking about the public health thing, I was thinking, I recently was able to go to Canada to visit my father on a compassionate entry visa because the borders are still closed. And there was like a serious check-in situation about the pandemic, right? And we didn't get my sister, when she was there, got the knock on the door, checking in on you. But yeah, I mean, that is really, confronting and scary, even, no matter what. And I can only even imagine how it is, like, just, in the United States, living in.
Oh my goodness. For me, it was kind of laughable. I mean, I was like, and you feel really bad because it's like, like it's not the person's fault. They're just working. They're just, I mean, it's just like, for me, it was like a young Black female, with a social work, with, just, but like how to engage, people, same gender loving Black males, how to have that conversation, how to make it feel like, in one sense, I'm just like, poor thing, like who is sending these people out into these neighborhoods?
Yeah,
like,
the systemic structural stigma involved in that is just like so multi-layered. It's just incredible. And plus the whole like public health and people of color and just, oh my gosh,
all the things.
But I also just, I just was going to say, like, I have a friend who had an experience, and I don't want to use too many details because I didn't talk to them about sharing this, but I just have a friend who had shared in one situation about their status and then was like publicly asked to speak about it. And I was like, they just outed this person, like, just crazy, right? And of course they handled this with enormous grace and vulnerability, but I thought people just are not thinking about, if somebody shares that with me, that doesn't necessarily mean that they're out in every situation, and particularly regarding I think the faith communities, I think, is a huge one. Melanie, go ahead. What were you going to say?
Yeah, well, I was thinking that, it's while the conversation is around stigma and HIV, it extends to young people wanting to access contraceptives or just barriers so they can prevent transmission. easy enough for people to say, oh, go to the doctor and get screened. But if your parents have your insurance coverage, or if you don't have insurance and don't have the cash to cover it, or you don't have a car to get yourself to a clinic, and you're in a rural area, these things are just tough. When I taught our whole lives, when I was a facilitator, in the particular town that I lived in, we didn't have a Planned Parenthood or a free clinic. So I would say, look, what you do is the movie theater in the next town is right next to Planned Parenthood. So go to a movie that you've already seen before, schedule your visit to the clinic. Your parents will drop you off at the movies. You go to the clinic, you go back to the movies, your parents will pick you up. They don't have to know, because you already know the story of the movie. So if your parents ask you what happened at the movie, you already know. So that was the one little help that I could offer them, because they couldn't get to the clinic any other way. We didn't have public transportation where we live.
Yep.
So I think we can, translate what you're all talking about, the outing thing, the difficulties in access to all kinds of STI prevention and certainly pregnancy prevention.
Yeah. I was going to say too, there's this, and then we have a question in the chat too. I'm sorry, Michael. We're all like, "Wah!" Also, I just know, like, even in our materials, we have information about how the risk of transmitting HIV is minimal through oral sex. And yet I know someone who contracted HIV through oral sex. So I always, when if ever I'm reading that, I'm just like, yeah, and it still can happen. So there's just a lot of information and a lot of things that we need to not just be cavalier about, I think, especially as sexuality educators. What were you going to say, Michael?
No, I was just going to say, the solutions are simple. I think, the more conversations that we're able to have, the more comfortable people are about sex, the more comfortable people are about, because I think that the stigma comes from a place of concern, like I mentioned, I was raised, in the South, the Black South, and, and it's where it's less about hate and more about concern, because, there's so many social determinants to overcome that we're just raised to, be as careful as possible so that you might survive, and whether it's, being approached by the police or, disclosing, your sexuality as gay, or, being a teen mom, all the things are, the community kind of grieves because we're already grieving. You already begin at a on the back foot, if you will, when you're Black. And so I think that, having these conversations, particularly in communities of color, is so important, because there's a thin line between self-harm, and self-care.
Yeah.
Self-harm and self-care. Arthur.
Yeah, no, Mike, I was going to say that, it's why those dialogues are important, the conversations, the data is important, and for people to come to a safe place to get that information. It's critical what Reverend Mike was saying about, how HIV 40 years later is transmitted and how it can be transmitted. Things have changed. So it's important to hear that if a person is on their regimen and that they're undetectable and what the risks are and transmitting. And there's other options now for people who want to participate and be active, where they can take certain medications, PrEP, so that they can protect themselves as well. And that fear and the not knowing perpetuates that stigma. And I remember that in the storytelling that a woman shared with their religious leader about their status. And as things happen, as that person became a worker in the church and did more things, and life improved for her, where somebody was interested in her and went to the pastor, like, you know, good congregate would go and say, hey, I like sister so-and-so. And the pastor's response was, oh, she has HIV, I wouldn't deal with her. But if they had benefited from that information that's provided and that data that's provided at being at the table and engaging in a dialogue such as the framework for dialogue, he or she would have had that information and would have known what to offer that person who was interested in that other person, instead of, you know, inflicting more pain and more lack of trust in that community. But it's important to have that data, and it's important to have the conversation and to be open to hearing it, so that what you're saying from your pulpit or from your platform is to know that that's impactful, and how that impacts the community, and how that dispels all types of stereotypes and negative information and those kinds of things.
Yeah, and I just think that's so important. And I know Melanie and I are just working really hard, and we're not alone in advocating for equipping our religious leaders with information that they need, because they are people who are sought after in terms of a lot of questions around sexuality, yet they don't have, generally speaking, a whole lot of education around that. We do have a question in the Q&A, which says, what impact do you think COVID-19 will have on HIV/AIDS stigma long-term? Are there ways that people have built more skills to have conversations about risk reduction, or are there negative impacts we might see? I'm like, yes. What would you say, Michael and Arthur?
I would say
Go
that,
first, Mike.
Sure. I would say that, again, social determinants. You know, like I remember at the beginning of COVID, you know, there was basically a lot of internet chatter around like how many people of color at first didn't seem to be catching COVID. It seemed like we might miss this one, but only a few weeks into the pandemic, we realized that actually, you know, Black and brown people were certainly much more impacted by COVID, and I think that, you know, COVID reveals that there's so much work left to do in public health, not just in treating folks who you know, who contracted COVID, but also like immunizing folks from contrasting COVID. I think that COVID, I believe, is going to serve, you know, the HIV pandemic, HIV and AIDS, in letting people really understand that it's less about behavior. People of color, gay people, trans folks are not having any more sex than anybody else. You know, it's not about how we have sex. It's not about who we are. It's about how we're treated in society. The systems that are accessible to us, opportunities, education, housing, healthcare. It's, you know, we're all having sex at the same rate. I'm pretty sure. Nobody's missing out. I just think that it's all about how you treat people's sexuality and sexual preferences and identities and social locations. And I think that COVID, because it had nothing to do with behavior, it was not like, oh my gosh, he was unprotected by a mask, and that's why this person got COVID, and this person was like, in a lot of ways, because it was just unequal, and, you know, so, but like, because everyone got it innocently, if you will, it was proof that our systems need to be changed, and how people receive treatment and receive care and receive vaccinations and healthcare. And so I think that that will go a long way, and not just HIV and AIDS, but allergies, diabetes, all sorts of healthcare risks that people of color, poor people, and people in the South have a hard time overcoming.
Yeah. In messaging, I think that COVID created, and all of its destruction created an atmosphere where it opened people up to having those conversations and how we protect ourselves, whether we choose to protect ourselves. There's the difference in, do I wear a mask? Am I gonna wear a mask? Am I not gonna wear a mask? Is this a conspiracy or is this the truth? Am I gonna wear a condom or am I not gonna wear a condom? Some of the same things that Reverend Mike and I know were the conversations back, in the 90s, were the same types of conversation, but it was around COVID. And so there were a lot of parallels, but it wasn't about the specific disease that was the disease of the day. It really was about perceptions and how we perceive and who we think is susceptible to getting certain things. And if it was a man's disease or a gay person's disease, well, I'm heterosexual, I don't have to worry about it. It was somebody with pre-existing conditions and I don't have any, well, I don't have to worry about it. If it's related to a specific area, well, it has nothing to do with me. And so it opened us up to having the conversations. But I think some of the more successful strategies came out of those early conversations. I'm going to continue saying why it's important, why something like the tool of the framework for dialogue is so important, because it just opens us to a place where we can have the conversation. It's important with a curriculum such as OWL to have the conversations and to allow people to see things very differently than what they were told. They get to look at it and make a determination, because it's really about self-care. But if I don't know how to take care of myself, then I'm going to always be at risk.
I think one of the things that, we do teach people how to have the conversation about assessing risk in our whole lives. And as you mentioned, that the transferable skills, now that congregations are talking about, maybe getting back in person, and we're having to have conversations around, do we ask people to get vaccinated? Do we cross our fingers and hope they'll get vaccinated? I had an elderly friend come over Saturday. I had just assumed that she had been vaccinated. I was wrong. 90 minutes into our conversation, just on the other side of the dinner table, she said, by the way, I haven't been vaccinated. And I'm like, I'm not wearing a mask. You're not wearing a mask. We didn't discuss this. We should have had that conversation. But I'm not used to that. I go out in public. I wear a mask still because I live in an area where a lot of people aren't vaccinated, and I want to do my part to keep them safe. But it was weird, because had my friend said, by the way, I just found out I have HIV, I wouldn't have worried, because I'm not going to get it by having a conversation 3 feet away. But when she said that she wasn't vaccinated, and I know she goes to stores, she goes to dance class, she does all these things, she could be asymptomatic. And I could, I'm not, now we don't know, because there's variants. We don't know how good our protection is if we've been vaccinated. So that ability we're all going to have to get into the habit of having the conversations and assessing our own aversion to risk or our own willingness to trust whether, you know, we're making wise decisions. But definitely we're going to have those conversations in our congregations and churches and in our own private lives as well.
Yeah, and I think,
And I think,
go ahead,
Amy.
go ahead, Michael.
No, I was going to say what's so important, right, is like what happens after you have that information. What is the spiritual assessment body scan that you have to do, and how do you engage that person to provide them with the information they need to make responsible decisions, and then how do you treat them socially? And I think that, you know, so often we've talked about, you know, HIV and AIDS, but in the interpersonal dialogue, in the conversation, what are the pastoral care resources? What are the religious education resources? What is the next sentence? What is the next thing you say after hearing that information?
Oh, I can tell you, Michael, because my body was like, what? Because it felt like a real breach of my ability to give consent. Because you know, had she told me before she came in the house, I would have said, no problem, just let's both wear masks.
Mm-hmm. Which,
and my response again will be the next time she comes over, let's both wear masks. But it disempowering, and it's a jolt to the system when your choice is taken away to protect your health.
So when you insert dinner with sex,
yeah,
you know, like that becomes the thing, like after the fact conversations, what would drive someone to make that decision without, you know, to make the decision to take away your power. But now that you know what resources are available, how do we understand ourselves autonomously and our agency, and how, all of those things are deep questions that I'm sure Arthur is more than qualified to talk about.
And I think too, like I'm sure like stigma was in there, right? Like
that's why I'm like,
there must have been some stigma, right? Some stigma in there about like, I don't know if I should say that I'm unvaccinated, right?
Oh, totally. I don't even understand what a vaccination is,
Right. And there might be some other places where that's flipped. Like, I don't want to tell people I'm vaccinated. Like there's places in this country where that, so another thing that I was thinking about as we kind of draw to a close here with our time, but so I have a friend who does work internationally, and he was sending me some information about a document that's being sent around. I'm not sure if it's a UN group or whatever, but to many different countries. And there's this controversy about whether or not to call HIV and AIDS a pandemic or an epidemic, which just seems so honestly ridiculous to me at this moment, when we have already defined something that's a pandemic that hasn't killed nearly as many people as HIV and AIDS has. So again, with the stigma, right? And a lot of times this is also connected with that faith piece. So I'm just wondering if just as we kind of wrap up here, if both of you would speak to just briefly to something that most of the people on this call, I think, are either Our Whole Lives facilitators or trainers or affiliated, you know, in some way with a faith community. So what can they do as Our Whole Lives facilitators and members of faith communities to further this idea that the stories and the data are important together to break down stigma?
Wow. So first, thank you, Melanie, because we are in the process of creating a toolkit for the Framework for Dialogue and the Stigma Index, and marrying those two. And what you highlighted in Our Whole Lives is that assessment, being able to have that self-assessment. So I'll be sure to mention that to the writers of that toolkit. So thank you for that model, because it is conducting that assessment, that self-assessment, that introspective look into ourselves. And, you know, I loved how Reverend Mike said he leads with that conversation right off, because it empowers him, but it also empowers the person that is about to engage in whatever the activity be, or even the friendship or the partnership is, you know. So I think it's critical for us to have those conversations and to know that the data is there to support. It's not the only source, it's one of many sources, but to have those people available and the data available so that it can it can transcend the conversation and connect the dots, and so that people know that it's bigger than how we sometimes perceive it or talk about it. So I hope that answers the question.
Thank you, author. I would say, you know, the church is behind. Surprise, surprise. The community is ahead. And I think that so many people, if we go back to what I was saying around like stigma doesn't begin with HIV, stigma begins with particularly for people who have marginalized identities, it begins with the identity, and it begins, and those of us who, you know, we progressive, you know, like we're evolved, but you know, coming from an evangelical mindset, I feel like we evolve ourselves out of talking about faith with people in public, you know, and so many of the people that we are allied with don't go to church because we're behind. And I think that the statistics allied with the stories, a lot of times we go out into the, as the Bible say, highways and byways, looking for a story to prop up our programs. And we must engage people in the community. We must become evangelical-esque in reaching out to people and partnering with social services and community health care centers and homeless shelters, and instead of just being in agreement theologically or philosophically, we must make our spaces welcoming and affirming to the people at the margins. We must begin to, as Christ, you know, exemplified, preferential option of the poor, and make our spaces, temples of, for the people, public, and less about, I'll end there.
Thank you so much, Michael, and thank you, Arthur. And I just want to say that's some evangelism I can get behind. Sometimes that's we have like the E word, evangelism. Sometimes in progressive spaces, that's not a word people embrace, but that kind of evangelism, I know I could get behind. Yeah. I want to thank you all so much for being here today and having this conversation. Just many, many, many blessings and gratitude to both of you for this rich conversation. And Melanie, thank you for your vulnerability and bringing in consent and COVID and all of that. I want to let you know that our next webinar will be in July, and I believe, I don't know the date, shoot, somebody look up the first Wednesday in July really fast. And it will be about framing a conversation about reopening and returning to our Whole Lives programs as things, kind of 2 steps forward, 1 step back, kind of as we're opening up. So, so please join us for that webinar, the first Wednesday in July 7th. Thank you, Andrea. Bless you. All
Michael
right.
has to leave, so thank you, Michael.
Yeah.
And Amy and I wanted to let everybody know to keep an eye on Our Whole Lives training calendars. We will be starting, we're scheduling them now. We don't have the dates yet, but we're going to be offering 2 online facilitator trainings for the 7th to 9 and 10-12 grade levels that will be in August. So give us about a week to set the dates and the trainers, and then you can look at the OWL calendars on our UUA page and the UCC page.
All right, there you go. We're trucking right along into the future here. Thank you all for joining us today, and peace be with you on the rest of your day and your week.
Thank you.